Thank you. Can you see the screen? Is the screen visible?
Yes, doctor. Everything is perfect.
Okay. Oh, okay. I'm very sorry. I'm very sorry. So, I am Dr. Suseela, affiliated to Amala Institute of Medical Sciences, and I am a professor of clinical microbiology. Ours is a teaching hospital. So, today I am presenting the RGM, rapid growing mycobacteria, which is an infection, and we can consider it as an entity in diagnosis. So I will present some cases that I have met in our laboratory. Aim of this presentation to analyze case reports were implants associated infections caused by rapid growing mycobacteria. Second, to describe that all granulomatous infections are not always due to Mycobacterium tuberculosis. To introduce RGM, they include Mycobacterium fortuitum, chelone, and abscesses. They are widely distributed in the environment. They may contaminate water supplies, reagents, and water solutions used in the hospitals. So they can produce hospital-acquired infections and also natural infections of lungs, or it can produce like Mycobacterium abscesses, which can produce abscess in any organ of the body. So there are many. Why? Because there is a clinical spectra. So many medical devices like meshes used for hernia repair can be infected, or it can be a non-healing wounds following surgical procedures, or it can be even the patient may come to you after a long time of surgeries, for example, LSCS with abscesses on the scars, and in cosmetic surgeries. And also, we have seen intravascular infections following cardiac stents and IV cannula to the patients. The case series, case 1, a 50-year-old man admitted with swelling and pus discharge in the right inguinal region. The superficial culture means they send the sample from the superficial area of the wound, and the bacteria grown was Pseudomonas, and the patient was treated accordingly. The antibiotic sensitivity or susceptibility testing, it was susceptible to piperacillin tazobactam, but there was no response. Second case also, middle-aged man underwent inguinal hernia repair, again with the mesh, and developed swelling and discharge at the site after 5 weeks of repair. Third case, this patient, see, he was visiting different hospitals for 3 years after the inguinal hernia repair, and there was no relief. Finally, he reached to our hospital. Evaluation of lesions and identification of pathogen, the following points. The wounds were explored in all these 3 cases, and the meshes were removed in all these cases. And we did the routine microbiological examinations like a gram staining following routine culture. And in the gram stain, there were plenty of pus cells, but we could not visualize any organisms. So this is the culture appearance of this bacteria. It did grow on routine culture on Mekonghi agar, and we did the acid fast staining with the Seal-Nielsen technique by using 20% sulfuric acid. There were acid fast. So we did the culture on LJ medium, Lowenstein-Jensen medium, and we did see the growth within 5 days. So it was a rapid growing mycobacteria. And all these three cases we could confirm with the PCR as Mycobacterium fortuitum. The primers used TB11 and TB12 for HSP65. Case number 4 is the patient appeared with a history of fever, and the diagnosis was FUO, fever of unknown origin, and history revealed the placement of a cardiac implant. There was a stent, and in the as usual for every FUO, we are taking blood culture. So in this patient, the blood culture number 1, even though it flagged positive, but identified as contaminant. So second, third, and fourth blood cultures were repeated, and all these samples flagged positive within 24 hours. And we did gram staining. Usually, we are doing gram staining from the blood culture positive bottles to know what type of bacteria, whether it is gram positive or gram negative. In this case, we got irregularly stained bacilli. It appeared gram positive. And so it was irregularly stained. We did acid fast staining with the Zeal Nielsen technique, and they were acid fast. So we did subculture to Mekongi agar, then rapid growing mycobacteria grown, and the organism was identified again as Mycobacterium fortuitum. Case number 5, the patient was a child, 3-year-old, and patient was brought to the hospital with a swelling in front of the right ear. USG examination, ultrasonogram showed the features of tuberculosis and clinically diagnosed the patient as tuberculosis. And the histopathological examination by taking INT plus the wall of the abscess was taken for histopathological examination, and the HPE showed granulomatous change, again suggestive of tuberculosis. We did in the laboratory the Zeal Nielsen staining, and it showed acid fast bacilli. But meanwhile, we sent the sample, or we did the sample to the molecular lab for the CBNAT examination, and there was no mycobacterium tuberculosis. So there were granulomatous changes in the HB, but and also USG examination suggestive of tuberculosis. But in the CBNAT by gene expert, we could not see any gene for MTB. So before that, we had done the routine culture, but we could not get any growth on Mekongi agar, blood agar. But we had done the conventional culture on LJ medium for this bacteria, and we got the growth within 5 days. So this is the appearance in the USG and the granulomatous appearance. This is the patient with the swelling in front of the right ear. And this is molecular diagnosis, identification. So coming to discussion, cases 1, 2, and 3 were infections of inguinal hernia repair where polypropylene meshes were used. So what was the morbidity to these patients? There were non-healing of the wound or healed wound began to ooze, leading to chronic suffering. The culture of superficial specimens and antibiotic treatment for colonizers. Wound exploration and removal of the mesh, and it needed readmission for the patient. So it was again suffering to the patient. And patient needed prolonged treatment for this entity. And the cost of the treatment also was high. Was it an outbreak? because we could not say that it was an outbreak because all these patients underwent the procedures in different hospitals. The suspected sources for these bacteria are contaminated instruments, or maybe the water used, or the gases used for during surgery. If it occurs as an outbreak, by outbreak investigation, the source may get revealed. But here we could not detect the source. Tracing out the source in sporadic cases is difficult because patient may be appearing with a complication after a long duration. Case number 4 was investigated for FUO, and the positive blood culture made the diagnosis possible. What was the problem for the first blood culture? It misidentified as contamination. It points out the lack of awareness to the microbiologist. So cases 1, 2, and 3 were cured by treatment with the clarithromycin and ciprofloxacin. Case number 4, we gave carbapenem also because patient was having fever, and there was initial relief for this patient. But with the recurrence of fever, patient was planned for removal of the stent, even though it was a very um, difficult procedure, the removal of the stent. But before the removal, patient developed multiple aneurysms in the blood vessels and expired. Problems we consultant microbiologists face to convince the physicians about this entity, and also we cannot do always the AST, antimicrobial sensitivity susceptibility testing, because it is laborious micro broth dilution, and we have to suggest appropriate antibiotics because there is no guideline for the treatment. How can you prevent these infections? For this, you need strict aseptic precautions during procedures and proper sterilization of instruments and gases, proper sterilization of water or the solutions used for wound irrigations or flushing of scopes. Case number 5 was a boy. I told you that the patient was a child and clinically diagnosed as tuberculosis. Our country is in the verge of elimination of tuberculosis. And in this case, tuberculosis was ruled out by culture of the pus sample and molecular identification of the pathogen to subspecies level. The child was successfully treated with the clarithromycin and ciprofloxacin for 12 weeks. Algorithm which help for this identification in this case, the Steele-Nielsen staining of pus sample showing acid-fast bacilli, and we could not get any growth on routine McConkie agar or Glad agar culture media. And CBNAT for MTB did not detect any MTB. We did culture on Lowenstein-Jensen medium, and growth appeared on 5th day. So the rate of growth, it was less than 1 week. And the growth was confirmed as Mycobacterium abscessus subspecies mesiliens by Sanger's sequencing. Mycobacterium abscess, to talk about the antibiotic resistance, it is notorious for drug resistance. If you do subspecies identification and if it is found subspecies mesiliens, it is better. Granulomatous, the lessons from this case, granulomatous lesions should be evaluated for organisms other than MTB. Culture is a good tool to differentiate the organisms. No blind treatment for tuberculosis for granulomatous lesions. Natural infections with the mycobacterium abscess may present with the granulomatous changes. For example, in lung, they can cause infection, granulomatous changes. And presence of acid-fast bacilli, rate of growth of these organisms, then we have to do the molecular testing of the sample to rule out mycobacterium tuberculosis. Gene sequencing and identification to subspecies level will lead to optimum treatment. That is the aim. Because ERM41, it is the inducible gene. So the expression we have to, in mycelians, the expression of ERM41 is negligible or absent. The subspecies like mycelians is less likely to produce drug resistance. As antituberculous treatment is not useful for this NTM, non-tuberculous mycobacteria, correct identification and drug susceptibility study are essential. To conclude, RGM infection may be considered as an entity for clinical diagnosis. Granulomatous lesions should be treated accordingly because other granulomatous, other than this NTM, other bacteria also can produce granulomatous lesions. So microbiological testing is very, very essential. Evidence-based treatment will reduce the suffering of the patient, and awareness among physicians as well as microbiologists about this entity is very essential for optimum treatment. So these are the references. Thank you for patient listening. Any questions? I will try to answer.